team at Thrive Aged Care Consultants. I'm really passionate about person-centred practice, supporting autonomy and helping care teams feel confident in applying supported decision-making principles in their everyday work. So in the photo here, you'll see the two directors at Thrive as well. You'll see Kate Lamont, registered occupational therapist, and Kathy Kirby, registered nurse, and they're both here online as well, and they'll be monitoring the chat today. So at Thrive, we're a team of experienced clinicians and consultants supporting residential, community, aged care and health services. We provide practical education, mentoring, quality improvement and consultancy services to help organisations really strengthen workforce capability, improve outcomes and navigate the ongoing reforms with confidence. So if we can be of any help, be sure to reach out to us for a chat. So a little housekeeping before we get into it. If you could just put yourselves on mute, that would be great. You can make good use of the chat. And as I mentioned, Kathy and Kate will be monitoring that. There will be time for questions at the end, and we will stop the recording of this session so you can feel confident to ask your questions and engage at the end. As I mentioned, this session is going to be recorded. It will be uploaded to our YouTube channel. So you're free to use that recording for your own training with your teams. But just don't forget to like and subscribe to that channel because that helps us out a lot. And after today, you will also get a copy of the slides in PDF format and a link to the recording. So let's jump on in. So this slide will cover what we're going to talk about today. So we're going to start by talking about what actually is decision-making capacity in everyday practice. So we're not going to cover too much theory. It'll be pretty practical. We're going to walk through some of the common situations where concerns tend to come up, how to respond in a way that supports the person, really using least restrictive approaches. We're going to spend some time on that balance that we're all trying to navigate between safety, dignity of risk, and duty of care. That's often where the real tension sits. And throughout the session, we're going to be focusing on practical strategies and approaches that you can apply in your day-to-day work. So I want you to think about the last unwise decision that you made recently. And I'd love to hear from you, so you can use the chat function. So, you know, it might have been something like you ordered Uber Eats 3 nights in a row last week, or you bought something on impulse that was very expensive, or you spent a lot of time last night on social media doom scrolling and you didn't get to bed till after 1 a.m. But it could be anything really. And so do you think that someone should determine your capacity to make decisions based on that alone? And so that's actually what happens a lot in health and aged care settings. We make decisions that take away someone's autonomy very soon. So if we wouldn't be comfortable for that happening with us, we really shouldn't feel comfortable with that happening for our clients and patients and our residents. So before we get into a formal definition of decision-making capacity, we need to ground ourselves in some basic principles behind it. And the first one is that all adults, that's anyone over 18 years, we have the fundamental human right to make decisions about our own lives. And that means that we always begin from a place of respect and presuming that a person has capacity, unless there's clear evidence to the contrary. So we don't start by questioning someone's capacity. We start by making an assumption that they can actually decide. And that's a rights-based approach. It protects autonomy and dignity and self-determination, and it helps people to stay in control of their own lives wherever possible. So the other thing to say at the outset is that it's important that even if we don't agree with someone else's decisions or choices, that's not enough to question their capacity. So people are entitled to make decisions that are different to ours or are unpopular or even risky, just like any of us. So we need to keep that in mind as well. So in a moment, we're going to look at the specific abilities that make up decision-making capacity. But really, this is the foundation, that all adults have the right to decide. And our role as clinicians, practitioners, and whatever our role is, it's there to support that right. So, from a legal and a clinical perspective, decision-making capacity is a process by which a person makes a decision. It's not the outcome of the decision. So, it's that decision-making process. And it is underpinned by the ability to understand the information relevant to the decision and the effect of the decision, being able to retain information long enough to make the decision, be able to use or weigh the information as part of the process of decision making, and be able to communicate the decision and the person's views and needs as to the decision in any way. So that can be if they speak or use gestures or any other means. So we need to be able to support that. So it's not an all or nothing process. So decision making is, it's not that someone has it or doesn't. In reality, it's much more nuanced. So capacity is domain specific because it varies depending on the type of decision. So a person can have can have no difficulty whatsoever making everyday personal or lifestyle decisions, like what to wear, what to eat, where they want to live, but they might need some extra support or help from a formal decision maker for more complex decisions around managing finances or consenting to serious medical treatments. It's also decision specific. So even within the same domain, it's not uniform. So someone might understand and consent to a simple medical procedure, but they might not have the capacity to consent to major surgery, for example, because it carries much more risk and it requires that more complex understanding. So we look at each decision on its own, not at the whole category. So that's what we mean when we say it's decision specific. And it's also time specific because a person's capacity can change over time. It can improve, it can fluctuate, and it could be because a person is recovering from illness, for example. So it's not fixed. And so really we have to remember that it depends on the type of decision, the complexity of the specific decision at hand, and the person's condition at that particular moment. These are really some common misconceptions when it comes to capacity. So just because a person receives a diagnosis, that does not automatically mean that they lack capacity. Just because a person has evidence of cognitive impairment, that too does not mean that they don't have capacity. Also, and the same goes with communication difficulties. We need to be able to support someone to communicate. If they're having trouble communicating, that too is not evidence of a lack of capacity. We don't have to agree with the decisions that are made, and the person doesn't need to agree with us to have capacity. So we need to respect that people are individuals. And a person has the right to make what might even be considered bad or risky decisions. That alone is not evidence that they lack capacity. And as we've mentioned, it's not fixed. It can change over time. So as I mentioned, the main point here is that we don't assume someone lacks capacity just because they've got some cognitive challenges or communication challenges, or because we're questioning whether we agree or we think that it was a good decision or not. So a person can still have capacity even with all of those things in place. So they might have difficulty understanding certain types of information, for example, like complex or abstract information, but they still might be able to understand the information relevant to the particular decision that needs to be made. And so for capacity, you don't need to understand everything. You just need to understand what's essential for the decision to be made. They might also have difficulty remembering information and can only remember it for a short time. And that too doesn't automatically remove their capacity. If they can hold the information for long enough to use the information, to weigh up the information and communicate their choice, so engage in that decision-making process, that's still valid. They're still able to have capacity intact. And as we've said, making a decision that leads to a negative outcome or something that we disagree with is also okay. We don't have to always make the right decision. We have the right to make decisions that end up not being the best decision. And so our job is to support decision making, not to judge the outcome of the decision. And so just a little bit more on this. At the start of the session, I asked you to think about the last unwise decision you made and whether that decision alone should determine your capacity. And really, this slide just goes into a bit more detail. The difference here is there's a huge difference between an unwise decision and a lack of capacity, but they are often confused. So on the left side, the definition of unwise decisions might be that it's risky or reckless or not in the person's best interest. It also could be an unconventional decision that you haven't seen before. So long as the person can still engage in that decision-making process, they understand, can retain, can weigh the information, can communicate a choice in some way, that is enough to say that they are able to engage in the decision-making process. So our job is not to agree with the outcome and that decision. So yeah, an unwise decision alone is never evidence of a lack of capacity. But on the right side, what could indicate a lack of capacity is when someone cannot engage in that decision-making process. So if they cannot understand the relevant information for that particular decision, if they cannot retain or use the information meaningfully for that decision, and if they cannot communicate the outcome of the decision, even with lots and lots of support, that might be evidence of a lack of capacity and a need for further assessment. So yeah, the take-home message is that an unwise decision on its own is never evidence of a lack of capacity. And these might just be some examples of a lack of unwise decisions, because they carry some level of risk and maybe we don't agree with them. But as I said, they alone are not evidence of a lack of capacity. So it could be that a person persists with smoking and drinking alcohol, even though they know it's a risk. Lots of people do that. And a person may be living in residential aged care who wants to continue to walk to the shops alone, even though the staff feel it could carry some risk there. So just because a person wants to engage in these types of decisions that we may not agree with, that carry some level of risk, again, that's not enough to take away a person's autonomy and to question their capacity. So if that's not enough, what is? And so this is really where the concept of triggers comes in. It's really important. They're the signs or the circumstances or the behaviours that do prompt us to question and consider whether we need to assess capacity. And it's particular to the specific decision at the specific point in time, we always say. So we're always starting from that point of presuming they have capacity first. That doesn't change. But a trigger is when we're concerned about something and we really need to raise the alarm and escalate. And so examples might be things like repeated decisions that place the person at risk, sudden changes that are out of character or inconsistent with their past values, changes in thinking or communication, and even financial concerns or possible exploitation. These might be reasons to question whether a person has capacity and to seek some further advice. These examples, though, are not triggers. So if a person disagrees with, but it aligns with their values, choosing options that are not recommended, as we've talked about, those two examples I gave before, taking longer to decide, to make decisions, or needing reminders, or accepting advice or support from someone you trust, they're also okay. That's part of the decision-making process, and we all do it. And having minor memory lapses that don't create a level of risk and don't impact on day-to-day functioning, that also is not enough to escalate and question a person's capacity. So when we do refer for formal capacity assessment is when there's a specific decision to be made, there's a level of risk or consequence that comes with that decision. There is a clear trigger, and we just went through a few examples, and there needs to also be evidence of a disability or cognitive impairment that is affecting the person's decision-making process. So their ability to understand information, to retain it, to use or weigh it, to communicate, to appreciate the foreseeable outcomes, and to rely on beliefs that are, or if they rely on beliefs that are clearly inaccurate or delusional, that is another reason to refer for formal capacity assessment. And then lastly, we must have tried support strategies and least restrictive options first. And if we're still concerned, that's when we would refer for formal assessment. So this is a really quick decision tool that we've put together, a way for you to have a rubric here that reminds you of what we've just gone through. It's a step-by-step process. The idea is that you go through each of these questions, and if you get an answer yes to all the questions, that's when you would proceed to a referral for a formal decision-making capacity assessment. So then is there a, so yeah, I won't repeat those, pardon me. I'll just leave that there for you for future to use. But yeah, it's a pretty simple tool. And so I mentioned the last step that is that we need to make sure that we've considered least restrictive options first before we would proceed to a formal assessment of capacity. And so when we're talking about least restrictive options, this is exactly what we mean. So instead of jumping to a formal assessment, we start by focusing on what the person can do, their ability level. And then we look at the right supports and how we can help them to make their own decisions. So yes, we start with the person's abilities, their strengths, their cognitive abilities, their communication skills that are intact, their lived experience, their own preferences, no matter what level they're at. There are almost always some abilities that we can build on. And then what we would do is we'd look to add support to that. And support doesn't mean taking over. It means adjusting how we present information, or we might give the person some more time. We might reduce distractions. We can bring in a trusted person to help them make the decision. We can use some visuals. We can break down the decision into smaller steps. All of those things are appropriate supports that we could add. And when we put the person's abilities together with the right supports, what we create is decision-making capability. And in many cases, once the supports are in place, the person really can make their own decisions, and we can completely avoid the need for a formal capacity assessment altogether. We can support them in an informal way, and that's really the best practice approach. So this is what we're talking about when we're saying least restrictive options. We want to avoid taking someone's autonomy away. We want to uphold the person's fundamental right to make their own decisions. And so this is a little bit more detail about how we might do that. Rather than taking away and looking at things from a deficit approach about what they can't do, we really want to start by supporting the person and helping them. And it doesn't mean taking over and making the decision for them. It's really trying to support that person, understand their perspective and what their values are, to help them come up with the decision themselves. And this sort of brings us to how we balance dignity of risk and duty of care. And so these are not opposite ends of the spectrum, but it's a delicate balance. They're not opposites. They come hand in hand. And what we need to do is really to support people to make their own choices and exercise autonomy, but we also need to manage the level of risk in a way that means that we're mitigating it and we're all on the same page, that we feel comfortable with the plan. And so this is the approach now that is embedded into the aged care standards, into the NDIS quality standards, but also healthcare standards. And the idea is not that we remove risk altogether, because that's just not possible anymore. It's not possible at all in life if we want people to have a meaningful life. But we want to mitigate risk where possible, and we want to come from a point of letting people make decisions and be in charge of their own lives and have autonomy. So, sorry, Kathy, there's just been a glitch here with the sharing, so I'm just going to have to stop sharing and start again.
No problem. The slides are moving. We're up to the case example. Do you want me to take control?
Oh. How do I do that? Can you share again?
Yep, I can do that.
Sorry, Kathy. It's just an error came up and it wasn't letting me do anything.
Okay. Can we see the
Let me take
slides?
control. Yep, I can see them. I will just quickly scroll through to where we were. Get back on track. Okay, thank you everyone for your patience there. Back on track. So let's look at what this actually looks like in practice when we're talking about the balance and the practical supported decision making in the real world. We're using a real example of Bill. So he's a 74-year-old man nearing the end of his life. He had advanced cancer and Alzheimer's disease, and he had some memory difficulties, but he was still able to express his preferences and what mattered to him. So in hospital, a decision was made clinically that he required a nasogastric tube because there was a high risk of aspiration and choking. And so you can tell, so this is where we had a trigger. There's a clear decision point with significant risk and consequence. And at this point, Bill chose to refuse the nasogastric tube and wanted to continue eating and drinking during his final days. And his wife, who was his main support person, agreed with his preferences. So let's talk through what we would do in this situation. Rather than escalating to a formal capacity assessment, what can we do that follows that least restrictive practice? So the first thing we would have to do is to start with Bill's perspective, really understand Bill. Bill wants to continue eating and drinking rather than using the tube because it provides him with comfort, enjoyment, and normality. Quality of life was really important in these final moments for him, and his wife was supportive of that. The next step along is to identify the risks and the benefits. So yeah, it's a real risk that he could aspirate and choke, and there could be infection and possible death. We know that. But we also have to think about the benefits, which is comfort and dignity and autonomy and emotional well-being. And yeah, duty of care really includes informing Bill of those risks, but not forcing him or taking over the decision at this point. The next step would be to consider the likelihood and the impact. So yes, aspiration risk is high, but it's high regardless of the feeding method. But the risk is also that if we took away oral intake altogether, that would cause a lot of distress. And so Bill understands the risks and accepts them, so does his wife, and they're really wanting to go with quality of life at this point. And so what we would then do is really try the least restrictive option. So we would go with oral intake to support his preferences and his goals. We've had a conversation with him and his wife where they're clearly understanding the risk and accepting it. And then what we wouldn't do is we wouldn't just walk away at that point. We would put in place some safeguards. We would try and mitigate the risk. We would put in place some strategies. Maybe we would do some assisted feeding. Maybe we would just only provide some small portions of meals, small amounts. And then we would have a stop and review point as well. And we'd have to clearly document this whole process so that we demonstrated that we'd gone through the risks, that they'd been accepted, we've put some safeguards in place, how we're going to monitor in future. And that really this really demonstrates what we've done here. We've acknowledged the risk, we've tried to mitigate it, and we've documented it, and we've done this while supporting Bill's goals. So when we're busy, we often don't walk through all of those key steps step by step. And so it's important for us to reflect, and you can do that in the chat function as well. Which step or steps do we often skip when we're under pressure? I think what I've noticed in practice is that we often skip the part where we talk to the person and understand their preferences and really take the moment to understand not only the risks, but the benefits of undertaking that decision as well. So they're the things that I've noticed, but tell me what you think as well. I'd love to hear. So I just wanted to talk you through some common pitfalls in practice, and that these are things that are unintentional, but they do carry some risk. So what we can tend to do is, especially when we get busy, we can treat capacity as fixed, that it can't change over time. We know that's not true because people can improve over time, especially if they're recovering from illness. And we can also treat it as a global issue, that someone has lost capacity for every decision. And that's also pretty dangerous when we go down that path as well, because we're taking away someone's rights to make decisions about their own lives. So we have to remember it's time specific and it's decision specific. That's the way that we manage capacity. We would only escalate to formal assessment of capacity after least restrictive options have been tested and we still have concerns. We have to be careful not to override a person's decision because it feels unsafe or unwise, or it's not, concordance with what the team is saying. And we have to be careful that we don't shift from stepping in and supporting to then taking over and making decisions for the person. And lastly, we need to make sure that we realise that it's not up to the care team to make a decision about whether we appoint a decision maker to substitute out. That's actually a legal decision. That's something you would have to go through the legal process for, and a VCAT or other tribunal, depending on the jurisdiction you're in, would make that determination. So yeah, just some common pitfalls to be wary of, because really the whole purpose for us is to support choice, to manage risk, and to document your reasoning. So take-home messages are that we're starting from a point of assuming that all adults aged 18 and above have capacity to make their own decisions. We also are clear that capacity is decision specific and time specific. If we're questioning someone's decision-making capacity, we're not taking away or questioning their ability to make every single decision. We've talked about unwise decisions and how they don't equal a lack of capacity. But if there is a repeated pattern where a person is putting themselves at significant risk, maybe that could be a trigger. And you may want to investigate further then. As we've said, a diagnosis or a problem with communication is not evidence of a lack of capacity. We want to always start with supporting decision-making and going with least restrictive options. And really supporting that dignity of risk, exactly how we did in the case of Bill. There was risk, we respected it, we managed it as best we could, and everyone was aware of the plan. And it's not about reducing risk altogether, because that would take away a person's meaning in their life. It's really about having a proportionate response. And that's really how duty of care fits in. And yeah, as we went through, we had a bit of a pragmatic risk framework that we worked through with Bill with those 4 steps to guide the process. So we'll pause the recording in a moment to give you a chance to ask questions. But before we do that, I did want to let you know that we have this an online course for clinicians and leaders in health and community and aged care on capacity. It's a self-directed course on the open learning platform developed and facilitated by myself. So you would work through short modules at your own pace. But we can also deliver this training in person for you and also live online if that would work for you. So feel free to reach out to Kathy. You can see her email there if you want to learn a bit more about what we can offer. So these are our channels that you can connect through to us. And we would love for you to take the time to provide some feedback. It's an anonymous survey with only 4 questions, and we really do value your feedback because we always want to improve. This is the channel the YouTube channel where this recording will go to. So please, as I said, like and subscribe. And this is how you can connect with us. But we'll send you a link with a PDF of these slides after today. Okay. I will give you a moment. We're going to stop the recording now. So this is a prompt for Kathy. Please stop the recording. We're going to take some questions, and thanks so much.